appreciate the opportunity to introduce this new system we've been working on for a few years. Got my disclosure, so I do have a consultant and royalty agreements with Medtronic is my disclosure that needs to be acknowledged. Oh boy, see these psychedelic slides, what's the deal here? Thank you. All right. So you know adult spinal deformity is very, very heterogeneous and difficult to classify. So so we're having trouble here. The slides aren't advancing. I don't have control over the slides advancement.
We're working on the slides here. I'm having a little bit difficulty making out your voice too. If we can maybe get you a little closer to the microphone.
Put on my headset if that doesn't work as well. I'm pretty close. Can you hear me back? Okay, is that better?
That's better. Yeah, that's better.
Okay. So I just can't advance my slides. I can share my screen. Or I can.
Dr. Lenke, you have
yes. Okay. I don't have an arrow. I used to have an arrow to do this. I don't have an arrow, so I don't have any control. No arrow on my laptop screen.
We're working on it here.
This Tuesday, there was an arrow. There's no arrow today. So.
Do you have it, Lee? Here, we're working on it, Larry.
You want to advance that? Can you advance for me? Or
that's what we're trying to set up, yeah.
I can just say next. We can just do that if you want, Bob.
Yeah. Hang on 1 second. Yeah. Here, I'm getting the signal that it's
I'm speaking, honey.
Just about ready. I see an arrow on there. So while we're waiting, I guess I'll quiz you. Having lived in St. Louis all those years, do you support the St. Louis Cardinals?
I'm a Chicago boy, so I'm actually a Cubs fan, if you can believe that. I grew up in Chicago, but obviously spent 30 years in St. Louis, so I think by default I certainly enjoyed and rooted for the Cardinals. But my wife is a native St. Louisan, so she's a diehard St. Louis Cardinal fan. So I have to say that by osmosis, I like the Cardinals more from her actually than anything. So.
Well, your wife sounds like a very wise woman.
I don't know how I got her moved to New York, though. That's the amazing thing, to tell you the truth.
Well, at least as long as you don't begin to support the Yankees, I think we can still be friends.
Yeah, although we take care of the Yankees, actually. The sports medicine head team doc is my partner, Chris Ahmad, great guy. So I can get tickets anytime I want, which is nice because they're kind of expensive, actually.
Yeah.
So you want me to share my screen? Would that be easier, or we're having difficulties here?
You know, if you want to start a sort of extemporaneously speak without slides, we could do it that way. We'll get them here. I'm sorry that it's taking a few minutes. You can't see it, but there's several staff scrambling around here trying to get the video feed set up. So I'm sure it's coming. I apologize for the delay. Why don't you let me ask, so what led you to, what did you see as the need for this, and what led you to develop this system?
Yeah, I wanted to tackle, a component of adult spinal deformity that I thought was more manageable to do this. As you know, Frank Schwab and others, ICC has done a great job in trying to come up with sagittal parameters and other ways of organizing our thoughts on treating, diagnosing and treating adult spinal deformity, but it's so heterogeneous, as you know. So if there's one area of adult spinal deformity that's more homogeneous, it's adult idiopathic scoliosis, and it really is a follow-up of the adolescent idiopathic scoliosis. So logical progressions, you'll see that we incorporate and leverage some of the AIS system into the ABIS classification system, because these are just older adults who have idiopathic curves that, usually have them as an adolescent, obviously, right? They just had progressed and often got more stiffer, but they're the same pattern. So, so you'll see there's some parts of the AIS system that we've used for ADIS in that regard. So it's a kind of a logical extension.
Yeah, that makes great sense. So I'm being told to ask you to share. Can you share your screen?
Yeah, I'll do that. How about this?
Okay, we're seeing it now. You just go to slideshow.
I'm trying to go to
There we
slideshow
go.
here.
Yeah, perfect. I think that's going to work.
Work? It's not on slideshow. It's not on the slideshow for some reason.
Is it under view?
Strange. Try one more thing.
Yeah, slideshow's there. Can you scroll up and hit slideshow? I see it on your toolbar. Yeah, there. There you go.
Slideshow when I hit it. That's very strange.
Is it not opening it?
The last 3 months. It's never been a problem. It's not to deal with.
Well, maybe, I mean, we've got a pretty nice size slide there. If you want to, maybe just want to click forward or click through.
Yeah, I can do that, Bob, if you want. So yeah, I want to start. So, again, the heterogeneity of adult spinal deformity is mentioned. Obviously, adult idiopathic sclerosis is just the adult progression of curves that we see in adolescence, even into older adulthood. Here's a 69-year-old with a triple major curve that she's had her whole life. Not presenting for actually lumbar stenosis symptoms, actually more than even deformity symptoms. Again, so younger AIS develops similar curves into the older ADIS, but just often larger and stiffer. So we wanted to leverage the well-known and now almost 20-year adolescent idiopathic sclerosis classification. It has this triad components of curve type, lumbar, and sagittal thoracic modifiers to a new system, ADIS. And we did this by kind of looking at the regions of the spine that we categorized. Obviously, in AIS, there's 3 regions: the proximal thoracic, main thoracic, and thoracolumbar. And the huge difference in the adult is that the lumbosacral region has to obviously be taken into account, because that can become structural, stenotic, and problematic, and often require fixations to the sacrum milling, where in adolescents, including 18-year-olds, we rarely have to do that. I was a little surprised that was done in the last case that was shown, but that's a conversation for another day. So the ADIS system, again, is radiographic. It's 2D, it's the same main means of communication. We want it to be simple, reliable, and by doing that, you make it modular. It's easy to remember, also to add on. As you'll see, we have to add an MRI modifier to this. We started out with only a radiographic classification, as you'll see, but I'll show a case that will demonstrate the need for MRI modularity component to this, which will come in the future. And again, having a familiar, leveraging the AIS system, we thought would be a huge advantage. So the Triad ADIS system includes the same curve type as the AIS system, because again, these are the same curves, but the modifiers are different. The first is the lumbosacral modifier, which is either non-structural, structural, based on the supine X-ray. And then the third component, second modifier, is the global balance modifier, whether the spine is balanced in the coronal sagittal planes or imbalanced. And if it's imbalanced only in the sagittal planes, then we call it a sagittal imbalance, coronal or combined sagittal imbalance. We get that from the upright X-rays as well. So again, the curve types are exactly the same. These are the same curves. We're going to assess the structural minor curves off supine imaging, not side benders, for a variety of reasons. But we use a single AP supine image, and that gives us our structural criteria, and the cutoff is 35 degrees. That curve, minor curve, is greater than equal to 35 degrees. That's a structural minor curve, and if it's less than 35 degrees, it's a non-structural minor curve. So instead of 25 degrees on side bending, we use 35 degrees on supine imaging. For the lumbosacral modifier, it's very simple. Obviously, the thoracolumbar kyphosis also would make these double major curve, even if the coronal plane was non-structural. This patient has a standard T4 to L4. Again, there's no reason to go to sacrum on this. We do this all posteriorly. A very nice radiographic correction with posterior osteotomies, and also clinical correction with the deformity correction 40 here. Again, a posterior surgery like this is 2 to 3 day hospital stays down in our hospital. So here's a patient that has a curve that breaks the rules. So here's upright X-rays on this. I think it's about a 60-year-old male. 32 degrees thoracic curve, 47-degree lumbar curve, 18-degree lumbosacral curve. Sagittal plane alignment reasonable. And we look at supine imaging on the far right. The thoracic curve is non-structural, not surprisingly. Lumbar curve is 28, but that's the major curve. And the lumbosacral curve is 14 degrees. So that's a non-structural lumbosacral curve. So the classification is telling us not to fuse the lumbosacral region. But the problem here is that this patient presents with back and leg pain and has significant stenosis at 3.4 and 4.5, as well as some femoral stenosis at 5.1. So we cannot not fuse and decompress and fuse the lumbosacral fractional curves. So we do this, so we have to do a T10 sacrum on this patient. So we kind of break the rules here. We don't follow the rules of treating this non-structural lumbosacral curve without fusion surgery because of the stenosis needed and decompression needed. And there's the standing photo showing good alignment, no PJK so far. A complex patient, a 69-year-old, again, a larger curve, a lot more stiff. You see the upright x-rays here, also kind of global thoracic and focal lumbar kyphosis. Supine imaging shows 41-degree residual thoracic curve, that's structural. 26-degree lumbosacral curve, that's structural as well. So this is a type 6 double major structural sagittal imbalance patient, so 6S SAG, a pretty common actually classification system in these older patients as they get sagittally imbalanced over time. So we treat this again all posteriorly, posterior osteotomies for the focal lumbar region, T-lip inner bodies for both correction and fusion of the stiff fractional lumbosacral curve. Here she is one of the post-op regional films and global films showing excellent alignment. Again, no PJK so far. Another patient now who has this deformity, obviously a little more imbalance noted on the x-ray, both in the coronal and sagittal planes. Also very rigid supine imaging, 36-degree proximal thoracic, which is structural, 50-degree main thoracic curve, which is structural, major curves in the lumbar curve, and obviously a structural lumbosacral curve of 38 degrees. So this is a type 4 triple major structural combined imbalance patient. So she's imbalanced in the coronal plane at 4.2 centimeters and imbalanced in the sagittal plane at 14 centimeters. So we have to obviously operatively improve these imbalances as well. So we do a T3 sacrum on her. Again, we get a reasonable balance in the coronal and sagittal planes. She has some radiographic PJK that's asymptomatic. That's obviously an issue in the 69-year-old who had a mild osteoporosis to begin with. And there's a global film showing good coronal and sagittal balance from a global perspective. Our global goal is to have the center of the skull vertical line hitting the hip, knees, and ankles. So we've accomplished that. But again, she does have some asymptomatic radiographic PJK already. In the last case, lumbar ADIS, larger 79-degree curve, a large rotatory focal lumbar kyphosis, and also thoracic lordosis, supine imaging, again, a structural thoracic curve above, structural lumbosacral curve below. So again, another 6 S for structural, but balanced patient. In this patient, we're going to do a posterior procedure not only to correct the focal lumbar curve, but to also do osteotomies to recreate thoracic kyphosis. So she has 12 degrees of thoracic lordosis pre-op. They actually create 42 degrees of thoracic kyphosis in her, and she also, you see the changed neck position following that kyphosing operation as well for the thoracic curve with a unilateral PSO of the apex L2 of the lumbar curve for correction of both scoliosis, the kyphosis, and the rotation aspect of the lumbar curve. Open procedure, and again, here's her standing film showing very nice sagittal realignment from the skull all the way down to her hip joints following this procedure. So thank you for allowing me to present this new radiographic classification system of adult idiopathic sclerosis modeled after the well-accepted and long-standing AIS system. Again, the 3 types are curve type, lumbosacral modifier, global balance modifier. We've shown excellent inter and inter-array reliability and various posterior treatment options. Obviously, we will plan to add a MRI modifier soon, but we wanted to get this out there first and get the radiographic component established and before we added the MRI component. But obviously, it's going to be absolutely needed in the adult population. So thank you for your attention. Happy to answer any questions you may have.
That's a fantastic contribution, Larry. One question that comes to mind for me is, you know, I guess in my mind, there's sort of 3 groups. We all know the degenerative deformities in adults, the idiopathics that have maybe progressed or become degenerative problems, And then there's a third group, which is kind of the iatrogenic spinal deformities. How do you distinguish, in your mind, what are your thoughts about the distinction between an idiopathic curve that has become degenerative and a problem in stenosis versus a patient who comes in with stenosis due to a de novo degenerative curve?
Great. That's a great point, and something actually we're working on right this minute to figure out, and or not me, but we think we figured it out, but we want to prove it. Obviously, one way is if they have a structural thoracic curve, almost invariably those are not degenerative lumbar de novo scoliosis patients. Those are adult idiopathics that have progressed from adolescence with their curves. The problem group is the lumbar idiopathic or versus lumbar degenerative de novo, which have similar curves. Obviously, they both can present with stenosis, with rotatory subluxations, L3-4, foraminal stenosis, L4, L5, due to a concave lumbosacral fractional stenosis. But we think the key is going to be, and we're looking at this right now, is that for the idiopathic group, their concave pedicles at the apex, usually L1 or L2, are much smaller than the convex pedicles. Versus the degenerative de novo group, the pedicles are the same. They're the same diameter, same width. They're not dysmorphic. And so we're actually, we have a study going right now, an RB-approved study to look at that. James and I are doing that. So that we think is going to be the key differentiator. Kind of makes sense, we think, but we have to prove it yet. That's our thought right now. Yeah, and I appreciate any comment on that.
That makes total sense. And how about in terms of approach to treatment? If the curve types are similar, the curve appearance is similar, does having it be a de novo degenerative curve change your approach to treatment?
Not really. Again, I'm kind of a one-stick guy. I do things posterior open still. I think there may be opportunity, obviously, depending on skill sets, to introduce the more invasive options for some of these patients. I'm all for that, obviously, as long as we're still obviously treating these patients with what the operation they need, doing the right fusion levels. Not fusing the sacrum in an 18-year-old, that's usually not needed for idiopathic scoliosis. I was a little surprised by that, as I mentioned, but just we can't have technology triumph appropriate indications and appropriate surgical needs. But we're entering a different age here, obviously, with progressing MIS techniques and other adjuvants like robotics and things are going to change our world. Obviously, I realize that. I'm all for that. Same time, I think we need to keep, there's some true deformity principles that we have to acknowledge, right? I mean, you have to treat the structural major curve. You can't end at the apex of a curve. We have to obviously respect the sagittal plane alignment, right? That has to almost overrule the coronal correction at times, and we have to maintain neurologic integrity. I mean, there's basic rules we have to maintain during transition from open to less invasive surgery, and I think as long as we do that appropriately, I think it's going to be a wonderful transition. I think 10, 20 years from now, we're going to have a much better field.
Yeah, I couldn't agree more. So I can't again see the panel. Lee, are there questions from other members of the audience?
Yeah, I have a question, Bob. Larry, would you talk more about how you're going to put in these MRI qualifiers? Is it only for stenosis, or is it for disc space collapse and degeneration, or both?
Yeah. No, I think it needs both, but that's we're working on it right now, but we think it probably needs both because obviously we need probably a sagittal cut to look at degeneration, especially if we're trying to decide in a non-structural curve, can we leave L4 to sacrum unfused, right? At the same time, obviously, I think the axial cuts are essential for stenotic conditions, right? So most likely we'll have axial cuts, 1, 2, 2, 3, 3, 4, 4, 5, 5, 1, and then a parasagittal cut. But the problem is, with larger curves, you can't have one sagittal cut to get everything, right? Because you start getting into foraminal areas in the sagittal cut, so you need several. So we're working on that right now. We haven't figured it out, but most likely there'll be two MRI lumbar components.
That would be a huge contribution if you can do that.
Yeah, we're working on it. I appreciate that.
Larry, I have a question about the EOS, because we started with the EOS for many reasons, both radiation and for getting a full view. Do you now feel that your classification should be based on that EOS X-ray?
As you see right now, these are 2D regional X-ray classifications. I do get EOS on all my patients, and obviously, for most of our adult spinal deformity patients, it can be very helpful. Now, most ADIS patients don't have horrible sagittal alignment. I mean, the one I showed that was off like 10, 12 centimeters, that's about as most as you normally see in an ADIS patient, without iatrogenic surgery in the past. So I'm not sure it's essential that you need EOS, but what we found out is that if you can see C2 and you can see the hips, you really can see 95% of what EOS provides you, as long as your knees are not bent, right? So the key is try and get as high up in the neck as possible on your regional X-ray, and try and get your hips, obviously, to get pelvic incidence and the pelvis parameters assessed. So that means the key if you don't have EOS, because obviously not many centers have EOS. But if you can see C2 to hips, then you're getting most of what you need that EOS provides.
But my question really is, earlier lecture today, we talked about hip disease.
Right.
I think that EOS lateral is really important for judging whether you have a flexion contracture of the hips.
Right, no, you're absolutely right. And having pelvic femoral malalignment, obviously the sacropelvic malalignment and pelvic femoral malalignment we have to assess. So you're absolutely right. I mean, EOS, I've been fortunate. I've had EOS now for, I think, 17 years. We were one of the first centers in the country to get an EOS machine. It's been a game changer for me to analyze adult patients, every single one of my adult patients, EOS the last 15, 16, 17 years. So it's a game changer once you have that. I can't imagine not having it now, actually.
Thanks.
You're welcome.
Any other comments? I see Dr. Polly looking like he wants to ask a question. No, you're good.
He's happy that I say put lumbar again. He loves that. So it's just part of it now, Dave. I didn't pick that up, buddy.
Okay.
That's a personal joke between he and I. Sorry.
Okay.